Hi guys, welcome back to Codemaster Coach, your medical coding tutor. As promised, I'm back. Let's review these 2025 official ICD-10-CM coding guidelines. Now I'm going to start where I stopped on the 2024 because the information hasn't changed. But let's move forward with 2025 official coding guidelines. Let me minimize my box. And let's get started. We stopped at selection of OB principal or first listed diagnoses. And it starts with one routine outpatient prenatal visit. So it says go to the guidelines. Okay, so with routine outpatient prenatal visits, when no complications are present, a code from category Z34, encounter for supervision of normal pregnancy, that's the Z34, should be assigned or used as the first listed diagnoses. And these codes should not be used in conjunction with Chapter 15 codes. But let me show you what I put. I put a little note on that one that just says, remember our rule of thumb. When nothing is wrong and you're seeking healthcare services, it tends to be a Z code. These codes should not be used in conjunction with Chapter 15 codes because Chapter 15 codes identify complications that occur during pregnancy, childbirth, and the puerperium. So if you're saying, based on the guidelines, that the patient there are no complications, it's going to be a Z code, Z34. Okay, let's keep going. Number 2, supervision of a high-risk pregnancy. Let's go to the guidelines. Number 2, codes from category O09, supervision of high-risk pregnancy, are intended for use only during the prenatal period. For complications during labor or delivery episodes as a result of a high-risk pregnancy, you're going to assign the applicable complication code from Chapter 15. And if there are no complications during the labor or delivery episode, then you're going to assign code 080 for encounter for full-term uncomplicated delivery. And for routine prenatal outpatient visits for patients with high-risk pregnancies, again, prenatal, high risk, those are not regular outpatient prenatal visits with no complication. This is a high-risk pregnancy. Those codes come from category O09, supervision of a high-risk pregnancy. Should be used as a first listed diagnosis, and secondary Chapter 15 codes may be used in conjunction with these codes if appropriate. So notice with the Z23 or the Z34 correction, you're stating that there are no complications. But with the high risk, it is a complication. Therefore, you can use other codes from Chapter 15. Let me make sure my notes cover all of this for you. It says category O09, supervision high-risk pregnancy, is used only during the prenatal period. If there are no complications during labor or delivery episodes, then code 080, encounter for full-term uncomplicated delivery, should be assigned. But remember, in order to use code 080, the delivery must be entirely normal, no fetal manipulation, it must be spontaneous, cephalic, which means head first, vaginal delivery, no postpartum complications present, no abnormalities during labor or delivery can have occurred, no antepartum complications. If there were any antepartum complications, they must be resolved before this admission. No procedures other than an episiotomy without forceps, episiorophy, amniotomy, a manually assisted delivery without forceps, administration of analgesics or anesthesia, fetal monitoring, induction of labor, and sterilization. Those are acceptable procedures for an 080 code, because an 080 says the encounter was for a full-term uncomplicated delivery. And these are all identifying, these are not complications, these are normal. And for high-risk pregnancies, the prenatal visits are coded with code 009 for supervision of high-risk pregnancies, and that should be coded first. And then I said a note here, secondary chapter 15 codes can be assigned with 009. So let's look at number 3, episodes when no delivery occurs. Number 3. In episodes when no delivery occurs, the principal diagnoses should correspond to the principal complication of the pregnancy which necessitated the encounter. And should more than one complication exist at all of which are treated or monitored, any of the complication codes may be sequenced first. On my outline, I put a note that just says, remember the rule of thumb. For the principal diagnoses, whatever is the reason for the encounter, that's your principal diagnoses. And if more than one complication exists, as long as it is monitored or treated, it can be coded, and it says in no particular order, but I put in purple, Codemaster Coach says, put that most resource consuming condition first. That's just a rule of thumb I try to teach my coders. Always put your most resource consuming code first. All right, let's keep going. Number 4, when a delivery occurs. Let's look at the guidelines for number 4. When delivery occurs, when an obstetric patient is admitted and delivers during that admission, the condition that prompted the admission should be sequenced as the principal diagnoses. We understand that which occasioned the patient in the hospital or encounter for the a visit for that encounter is the reason, principal diagnoses. But if multiple conditions prompted the admission, sequence the one most related to the delivery as the principal diagnoses. Because remember, delivery occurs on this admission. So whatever the reason that brought him in or prompted that admission that's most related to delivery is the principal diagnoses. And a code from any complication of the delivery should be assigned as additional diagnoses. And in the case of a cesarean delivery, if the patient was admitted with a condition that resulted in the performance of a cesarean procedure, that condition should be selected as the principal diagnoses. And if the reason for the admission was unrelated to the condition resulting in the cesarean delivery, the condition related to the reason for the admission, again, whatever necessitated the admission, should be selected as the principal diagnoses. So my number 4 just says, the reason for the admission is sequenced first. If multiple reasons, assign the condition most responsible for the delivery first. Now, should a cesarean section occur, then whatever the reason for the C-section should be selected as the principal diagnoses. But if the patient was already admitted for something other than the reason for the C-section, then whatever was the reason for the admission should be the principal diagnoses. I always say, there's a rule of thumb. You've got to meet criteria to be admitted to the hospital. This patient was admitted for something, and it might not even have been related. According to this, wasn't even related to the C-section, but it justified admission. So if it justified admission, then that's the reason for the encounter. Therefore, that becomes your principal diagnoses. Okay, number 5, outcome of delivery. Let's go to the guidelines. A code from category Z37, outcome of delivery, should be included on every maternal record when the delivery has occurred. Now notice I'm saying when a delivery has occurred. These codes are not to be used on subsequent records or on the newborn record. So I think that's pretty straightforward. Number 5, yep. Z37, outcome of delivery, should be included on the mother's chart and not the newborn's. And Z37, which is outcome of delivery, that category is not to be used on the maternal's subsequent records. Just the visit when she comes in and delivers, identify what was her outcome. Was it a single live born? Was it twins? Was it triplets? Was it one stillbirth and one live birth? Whatever the outcome was, that goes on the maternal record on the admission when she delivers. Should she come in during the puerperal, etc., you do not put that Z37 on those additional admissions. All right, C, let's see what C says. Pre-existing conditions versus conditions due to the pregnancy. Certain categories in Chapter 15 distinguish between conditions of the mother that existed prior to pregnancy. They call them pre-existing, and those that are a direct result of the pregnancy. So when assigning codes from Chapter 15, it's important to assess if a condition was pre-existing prior to the pregnancy, or did it develop, or is it due to the pregnancy in order to assign the correct code. Categories that do not distinguish between pre-existing and pregnancy-related conditions may be used for either. It is acceptable to use codes specifically for the puerperium with codes complicating pregnancy and childbirth if a condition arises postpartum during the delivery encounter. So my notes just say straight to the point. It is actually straight to the point, but I want to make sure I clarify something that I notice as I'm reading this. It is acceptable to use codes specifically for the puerperium with codes complicating pregnancy and childbirth if a condition arises postpartum but during the delivery encounter. Because think about a pregnancy. A pregnancy is broken down into 3 different phases. The woman is pregnant, she comes in for the delivery, or she may come in during the puerperium, which is the 6 to 8 weeks after delivery. So make sure, and what I had to do when I was learning pregnancy was go to main term pregnancy and look at all the complications under pregnancy. Look at delivery, and even look at puerperal or puerperium, and look at the conditions underneath. Try to identify at what phase did each of the conditions occur. Because if it occurred after delivery and during the postpartum, it's acceptable to use those codes. Okay, that's what C is telling you. And D, let's go to pre-existing hypertension in pregnancy. It says go to the guidelines. So D just says category O10, pre-existing hypertension complicating pregnancy, childbirth, and the puerperium, includes codes for hypertensive heart and hypertensive chronic kidney disease. So when assigning one of the O10 codes that includes hypertensive heart disease or hypertensive chronic kidney disease, it's necessary to add a secondary code from the appropriate hypertension category to specifically identify the type of heart failure or chronic kidney disease. And hopefully I've got a note. Yeah, remember, for specificity purposes, identify the hypertensive category to specify the type of heart failure or chronic kidney disease. Because remember, when you're identifying chronic kidney disease, you also need to identify what stage. Is it stage 1, 2, 3, 4, 5, or 6? So again, for specificity reasons, you need to identify in pregnancy as well as out of pregnancy. I always tell my students, anemia, pregnancy complicated by anemia. Well, then you can code that in pregnancy, but also code it outside of pregnancy because is it iron deficiency, vitamin B12, what type of blood loss anemia, what type of anemia is it? So code it in pregnancy in chapter 15 first, but then also for specificity reasons, code it outside of pregnancy. Go to anemia and identify the specificity of the anemia. And that's what it's saying here as far as the hypertension, the heart failure, or the chronic kidney disease. Identify it in and out of pregnancy. There is also a note that says, let's go here, see section IC9 hypertension. And guys, remember that. Those guidelines that apply to hypertension, which tells you to identify the type of hypertension, if it leads to heart failure or chronic kidney disease, those guidelines explain the specificity that you need with your coding. Okay, guys, our next video we'll move on to E, fetal conditions affecting the management of the mother. And that's the next part of our guidelines. We'll be starting at E. All right, guys, you wanted this. I'm back. Let's keep going. I'll be back with the next video. Moving on from here. If you have not yet subscribed to my channel, show me that you want my videos. Subscribe to my channel. My goal in 2025 is to hit 100,000 subscribers. We're already halfway there. We can do this with your help. Thanks, guys. I'll see you in the next one.